Thank you very much, Kevin, for inviting me. And also, I want to thank all the speakers who spoke previous to me today, because you have laid the foundation for me to come up here and hopefully be more comprehensive in what I'm saying. I won't have to speak to the details so much because they did such a great job. Also, the speakers, I learned a lot from you, and thank you, all of you, each and every one of you. I'm just going to speak, like Kevin said, in generalities, because staffing, of course, this is our goal, and we're trying to recognize how infectious disease places both patients and staff at risk, and then, of course, constructing the intersection between occupational health and safety within safety patient initiatives. I'll just say real quick that my background's in occupational health and safety. And what does that mean? It means that we take care of the nurses who are injured while working, okay? And a lot of what they come in with is they're injured while trying to take care of patients. And they are in a moral dilemma because of the amount of injuries and the type of injuries and the short staffing causing the problems. And we're going to go through some of the statistics and the evidence, because in nursing you have to prove evidence. Otherwise it's just anecdotal, and it's just a conversation between me and the nurses. So we have to show what we can for the research that exists. Okay, so the objectives describe the scope and impact of occupational injury and illness among nurses and healthcare workers, and to define the relationships between short staffing, hospital-acquired infection, gaps in knowledge about the impact of HAIs, nurses and the healthcare workers, and we're going to try to do that today. Okay, so here's our evidence, right? First of all, when you come to the hospital, when patients go to the hospital, they go there for nursing and doctor care, right? After the doctor's finished with them, often it's between them and the nurse. And the nurse is there doing what they call a nurse surveillance capacity, all right? So we had to do a profile. How did this come about? How was this question even asked? And it was asked because the IOM in 2000, we showed there were many medical errors being done, of course, people dying needlessly, and the research showed over and over again, 2000, 2001, 2004. And of course, it was the Institute of Medicine that brought this about. And then the second research was done in 2005, and we saw there was an uneven quality of care across the hospitals across the United States. Then the research emerged documenting the link between greater investments in nursing and better outcome for patients. We're starting to get closer now to the root of the problem here, right? And the research is showing it. So if any of you want to go there, Chris Pontus is just bringing your attention to it, and I'm speaking to it, because every day I get a phone call from a nurse that is broken, beaten, psychologically down, problems within the workplace. Now, I have worked in many different types of venues. I was a consultant for an insurance company and went to many different types of manufacturing, hospitals, nursing homes, cities, towns, and I am telling you, the state we are in right now is no joke. And this is based not because I have a PhD, which I wish I did get. I only have my master's, but the reality is taking care of these people took my time and energy. Guess what? When a person goes into the hospital, that's what it takes, time and energy to do that assessment. We're going to go through and show what that means, okay? So the hypothesis is the better the patient outcomes are achieved through more effective surveillance. There's a primary and vital function of registered nurses. They are RNs. And this is done by people in Pennsylvania. I love that school. And it's Ann Courtney, Lee, Eileen Lake, and of course Linda Aiken, which many of our nurses here know, and I'm sure others too. Okay, so what is the key intervention that nurses do? It's the surveillance. It's a process which the nurses monitor, evaluate, and act upon emergent indicators of a patient's change in status. This gal here spoke about that. This changes. That patient's status can change from moment to moment, day to day, hour to hour. The components include, and they're continuous, and the nurse has to be there, because without that nurse's eyes and ears in knowledge of that patient, the observation, assessment, and recognition, and then the interpretation of the clinical data does not happen. Does this make sense to people? So that's what leads to our decision making. That's what nurses do. That's what nurses don't even have time to articulate. They're too modest. They don't even know when someone comes up to them. Their brain is in survival mode. They can't even articulate and defend what they're doing for the patients. It's a leading, like I said, to a moral dilemma. Okay, organizational features which enhance or weaken nurse surveillance. Okay, nurse surveillance capacity is affected by organizational structures. That's what impacts safety, we know that. So staffing hours of work and overtime, education and training, expertise, teamwork and collaboration, and of course experience. Nurse practice environment and safety culture are one and one. The bottom line is, for any workforce in any country, after 9 hours, the body can only go 9 hours at optimum. Then there's a breakdown and mistakes that to happen. It's been documented, it's been researched, it's just not nursing. It's everywhere. So this is where it's a logical conclusion that if you ask, they're working 12 hours, that we're going to start to see errors. If they're short-staffed, even more so. Okay, so how do we see that there are some people within management looking at this? In April 2007, there was a survey, and a group of leaders from a firm called Leaders for Today, they conducted a national survey, and good for them, because what they did was they went to 852 hospitals, and these were what they call the suits. These were the the people who lead the hospitals. And their purpose was to understand what concerns candidates were looking for in their careers. Why? Because these progressive hospital executives, they wanted to make sure they had good help, right? So they're saying, why are we not able to staff with experienced people? So they did the survey. The questions focused on a variety of departments, positions ranging from within the C-suite, the clinical administration, non-clinical physicians and nurses. So this is where the survey took place among the 852 workers. It wasn't just workers, nurses. Okay, the results were both intriguing and troublesome, right? Because what they found, when there was great turnover and attrition rates among hospitals at key levels. So what's happening, for example, in the OR? If you got 3 people that are the bulk of your knowledge, and if they walked out, your younger people would not have that experience that these 3 older nurses would have. And this is proven by NIOSH that across the country, it was going on like this. So that was an area of risk. A shrinking talent pool as more hospital employees age towards retirement. This is what they found. The crowded online job board market and why it's ineffective in healthcare, and how painfully slow hiring process frustrates candidates and hurts hospitals. So even if someone wanted to work in a particular hospital, they're not getting in because it's all bottlenecked. Okay. And this is what they wanted to know. So the 4 main takeaways are: continuity in hospital employment is lacking, number 1. Nearly 43% had less than 2 years at a current hospital. What does that mean? Half of your staff is not quite on top of it 100% of what they're doing. They're still learning, because there's always a learning curve. You're always learning more and more and more. 65.7 had less than 5 years experience. 37% plan to leave their current organization within 2 years. And where does that put this? 68.6% plan to leave within 5 years. So from a risk management perspective, where would that put you? Any good hospital executive is going to realize that they're going to be in more trouble. So this just isn't a nursing issue, which it is. It's about nursing employment. But it's also a management issue. It's organizational. And thank goodness these leaders for today, I think it was, they were looking at this. The rapid pace at which hospital employees are switching job is widening the knowledge gap. Why is that? They're not happy. They're jumping. In the past, people would stay in the same hospital for years. For example, Rhode Island Hospital, when I knew nurses there years ago, because I had done some of my clinicals out of the ER there, and if I went back, which I went back not too long ago for something, there were still some nurses there. You better believe I want the nurse with the most experience, that is able-bodied and able to do the job. And they're there because they like their environment. We don't see that in too many places. Okay, the current hospital environment promotes high turnover. More than 27.4% left their job for a promotion or opportunity for advancement. 27.4. That's because they weren't happy, because sometimes it's bullying, sometimes it's pay, whatever. There's so many reasons why. Another 14.4 left for better compensation. And then the largest proportion, 58.2, here it is, left for reasons such as long work hours, frustration, and burnout. Now that can be controlled. That 58.2, they can be controlled within an organizational management perspective or a plan, okay? So those are the conclusions here, number 2. Number 3, the growing proportion of retiring employees sure, because there's not going to be anyone with the knowledge to do the work. The workforce is aging. Hospitals looking at a significantly smaller pool of experienced people to fill their positions. And 47.7 indicate they plan to retire within the next decade. So there's going to be more of a crisis. Now this was 2017, so not 10 years, it's going to be 9 years as this crisis is unfolding. And 22.1 expect to retire within 5 years. In the last takeaway, the hiring hospital process needs a tune-up. According to leaders for today, the hospitals lose candidates who land job opportunities more quickly elsewhere. Yes, we said that. Respondents cited speed and transparency as the top 2 frustrations for hiring process. And it suggests that hospitals will be the more competitive for attracting top talent if they can optimize the hiring process and move quickly. So those were the needs that were, and the recommendations that were made. Okay, so patient surveillance is the primary and vital function of nurses, we said. Again, it's the nurse's ability to deliver safe, effective, high-value care and depends largely on the work environment in which that care is delivered. It's also influenced by multiple factors. The next analysis we're going to give tonight is we look at the impact of nurses' perception of the safety of their work environment and the degree to which they believe their work environment is sufficiently resourced to complete essential patient surveillance tasks on every shift. Now this is huge because this is the worker themselves who's doing the job. And no matter what job you're doing, who's going to come in and know your job like you do? Tell me. It's you. No, every person in this job, I think, in this place has a job. And you know your work. Well, could I go in your place right now and know your job? I don't think so. We might have RN after a name, but I couldn't go do your job, right? We have an engineer in the room or someone in psych. They'd have the same qualifications, couldn't go in and do your job. So this means that we have to look at the nurse and understand that she knows her job and needs to feel safe within the environment that she's doing that job. Okay. So the role of workplace safety and surveillance capacity is a driving nurse and patient, we know this, is driving nurse and patient outcomes. Okay, so the components of a safe work environment measured on the survey now. This is on the survey. This isn't Chris Pontus speaking. This was coming from the survey. Safe patient handling and mobility. What does that mean? You know when you're in there and you put a patient in a lift, it's either overhead or floor to ground or seat to chair, whatever. It's a lift. You're not lifting them. RN to RN interaction. That means communication. The ability to speak to someone without someone walking away when someone's yelling something at you because you're trying to do something else, right? Which is usually what's happening with the nurses, right? And if someone's a little off hearing, if there's noise going on, you've missed it. You've got the wrong dose. You've got the wrong doctor's order. You didn't even get it, all right? It's not happening. So appropriateness of patient care assignments is another big indicator. So what does that mean? This means the patient mix, right? No, I'm glad the nurses are laughing because they get it totally, right? They get it totally what we're talking about. So this appropriateness of patient care assignments has to do with what they call a skill mix. And who's making the skill mix? Who's determining what that mix is? So what constitutes that appropriateness of patient care assignment is what they call a skill mix for people in here who are not nurses. The problem is some of the times on the admission, guess what? It's not an RN who determines what that skill mix is it? And then the RN is left trying to deal with the inappropriate mix of patients on the floor, and they're left to do a job where someone at the beginning of the intake, it wasn't fair that they were there in the first place. They were giving them a mess. They were making it worse. Meal break practices, guess what? They're not getting them. No one's eating. I don't know about my nurses call, we're not eating. I can't even go to the bathroom. Seriously. This is more like, I understood that as I was a child growing up. That was called a slave. Right? That was called, when you could not eat, you could not go to the bathroom. That wasn't fear, right? That. And then the shift duration. And we do education in the evening. And I'm here to tell you that we have nurses, we all know this, 12 hours is very, very common. But I actually have nurses doing doubles that come in to an education because they need that CE after 24 hours of work and they've done 2 shifts, which is not even legal. Not even legal. Yeah, I know, it's amazing. This is Boston, Massachusetts. It's not supposed to happen, just like a lot of things happen in this state, and not supposed to happen, but it's happening, okay? And it's happening because they share the information with me because that's what we do. We take care of them. Okay, I gotta move with this, sorry. Okay, so workplace safety has a more significant driver than the surveillance capacity. What does that mean? That means it drives their ability to want to do their job, and they feel secure if it's safe, more than the surveillance. The analysis found the work environment significantly influences nurse surveillance capacity to the degree to which the nurses can observe, monitor, collect, and interpret and synthesize patient information. So when they can do their job, they're comfortable. They're happy when? They're most happy when they can do their job, okay? And of the 2 work environment components, workplace safety had a stronger influence on outcome than perceived surveillance capacity. So even though they're happy they can do their job, they know they can do their job when they're in a safe work environment. One thing leads to another, right? I'm in a good, safe environment, I can do my work. Okay. And it's notable, the units where the nurses rated their safety and surveillance capacity as high were improved patient safety outcomes. It was on survey, they had them. More positive patient experience ratings. Guess what? Press-Ganey showed that. And higher RN engagement rates. Now, Christy Dempsey, she's the RN Chief Nursing Officer at Press-Ganey herself. Press-Ganey people came up with this. This isn't Chris Pontus. This is Christy Dempsey from the Press-Ganey group. She said that safety, which we know from Maslow's, safety is the foundation of the pyramid. Thank you, Christy Dempsey. Okay, so now inpatient on patient outcome, cost, and satisfaction, we have. It's pretty clear. Picture's worth 1,000 words. Thank you, Jonathan. This is Jonathan put this. Patient deaths, medical errors, right? And Jonathan's going to go through some of the cost of this and the statistics of it. Complications and infections. How does this happen? It happens because a wound becomes infected. It happens because a surface doesn't get cleaned. It happens because patients are admitted with no standards of what is allowable in a hospital when they come in, whether they're decolonized or not. They can come in with certain levels of MRSA, we're not even dealing with it at this point. It has to be researched. It has to be standardized. We have to talk about it. Readmissions. Why? Readmissions are happening because the nurses will tell you that they can't even take care of their patients. And patient satisfaction goes up when they are taken care of course. So nurse-sensitive indicators on the survey also: pressure ulcer, falls, medication errors, infection, pain management, and patient satisfaction. Okay, burnout. We get a lot of this. Injury and illness. This is the one area that I could speak to you for 3 days on. I have nurses calling me. They get picked up by a patient and thrown, literally, and their neck broken. I'm here to tell you, I'm not exaggerating this. The workers' comp system then does not take care of them. Broken limbs. 3 to 4 years to get 3 limbs fixed because it's 1 limb at a time, if you're lucky, with a lawyer. This is what's going on with the workers' comp system. Stress. There's a moral dilemma for our nurses. Do I take care of this patient They're constantly being challenged on what to do. And there's no voice for them. Dr. Eldridge said we have to be strong, we have to speak to it, and I'm not exaggerating this. I mean, I welcome anybody with a camera to follow me around and listen to my phone calls and watch what I do and watch what we see every day and take care of. And job satisfaction would, of course, be a better outcome if we had higher staff. And I'm sure, it's going to be other things, not just nursing. We need all providers to have the numbers they need to do their job. Okay, so a new study on staffing in the emergency room in 2018, Western Journal of Medicine found excessive patient assignments and lower staffing in hospitals and emergency departments patient. And someone said that they walked out, resulting in longer ED wait. Someone walked out. Yes, it was her. That was right. Rebecca, they walked out. When she was saying that, I was thinking of this slide. That's what people do. And look what happened. They walked out, and look what happened to her husband. Thank you. That's exactly the kind of thing that's going on. The likelihood patients won't be seen. A number of other studies show costs associated with implementing safe limits are offset by the benefits of better care and reduced RN turnover. Okay, so this is a survey that was taken in Massachusetts, and I'll just drill it down real quick. This is May 18, 2018. 86% of the nurses do not have the time to provide adequate discharge planning. 90% do not have the time to properly comfort or care for patients. 77% report they are assigned too many patients to care for at one time. And due to unsafe patient assignments now, specifically when the question was asked, 36% said we report patients' deaths that are directly attributed to having too many patients at one time. We know the mortality rate's going up. This isn't news. When you put things in perspective, the mortality rate is going up in this country when patients in the hospital. Here the RNs are saying this. 64% of the RNs report injury and harm to patients, and 66% of the RNs report longer hospital stays for patients. 72% of the RNs report readmission of patients, and 77% report medication errors. This is huge. We've known this. IOM has been saying this for years. This has been going on for years. The state of the nursing of Massachusetts, the survey is online. Okay. National peer review studies show higher patient assignments are associated with more deaths, medication errors, and readmissions again. Again, I am repeating myself, but I am showing you there is more evidence and more surveys and more research to show it. For every patient added to a nurse's workload, the likelihood of a patient surviving cardiac arrest decreases by 5% per patient in medical care. In medical care 2016, that's the reference. So for children recovering from basic surgeries, each additional patient assigned to a nurse increased the risk of readmission by a shocking 48%, okay? For every patient added to a nurse's workload, there is a 7% increased risk of hospital-acquired pneumonia, and that's to speak of infections, of course. 53% increase in respiratory failure, and that was another thing you spoke to, was respiratory failure, and 17% increase in medical complications. Agency of Health Care Research. So this is all quality control studies and other people saying the same thing. National peer review studies show reducing nursing staff is inefficient and can negatively affect financial performance. This is healthcare management. This study makes a strong business case. This is key because just increasing the proportion of nurses without increasing the total nursing hours per day can reduce costs and improve care. By reducing unnecessary deaths, this is huge, and shortening hospital stays. Okay, what does that mean? Just by bringing in more nurses, not necessarily extending the hours, just bringing in new, fresh people to be able to think straight and not be so stressed out. All right, we're not increasing the hours, so we're not increasing outpay of money. We're just bringing in more people to do the job. Implementing safe limits would produce significant cost savings, is less costly than any other basic safety interventions common in hospitals. Now, we understand there's benefits if they're full-time, and even part-time, they would have some benefits, but the cost, the savings would help offset that, including clot-busting medications for MIs and Pap tests for cervical cancer, which are huge medical breakthroughs. Those costs are huge, and this would say be higher, these cost savings. Okay, so what's it come down to? An ethical issue. It's the political will. Why spend the money on a broken system, on continuing the broken system and enhancing it? And why not empower something so that we can do right? The first principle of ethics is do no harm. And according to Lee Curtin, RN, she's a Dr. Lee Curtin, the American Nurses Association contends that ensuring adequate staffing levels has been shown to, again, reduce medical and medication errors, decrease patient complications, decrease mortality, improve patient satisfaction, and reduce nurse fatigue. When we reduce that nurse fatigue and we can think straight and make our assessment, people can do a better job, right? We decrease nurse burnout, improve nurse retention, and job satisfaction. Okay, so all right, so we're going to jump to the federal regulation. She had spoke to some of this. We have adequate numbers of licensed registered nurses and other personnel to provide nursing care to patients, but the regulations do not say what is adequate, nor who determines this. So the regulations are out there, but it's kind of fuzzy as to who and what that really means and who it speaks to. Does Medicare actually know when the staffing is not adequate? They're not giving us a standard of what that number is. The Joint Commission acknowledges the link between the positive patient outcomes, quality, safe care, and effective staffing. Again, the Joint Commission staffing standard state staffing effectiveness is composed of, and they have the number, they say number, competency, and skill mix of staff in relation to the provision of needed care and treatment, but they don't give us a formula, or they're not saying what that is. So here are the numbers when you go to the Joint Commission book, and when the Joint Commission comes to make sure that we're following, the hospitals are following, the hospital provides an adequate number and mix of staff consistent with the hospital staffing plan. But the hospital staffing plan may have worked one time, but they're not working now. I mean, I'm not trying to be a negative Nelly here. What I'm saying is something's not working. Regardless of all the regulations and in the Joint Commission, it's not working. And we need to do something. And it's not just about money, because there is a lot of money there. It's just that it's being misappropriated. The Nurse Executive establishes nursing policies and procedures and nursing standards and a nurse staffing plan. So this is what they say the hospitals have to do. They use data, the second one, H1.30. The hospital uses data from clinical service screening indicators and human resource. So this is where they get their numbers. We understand that. Okay. In spite of the data, these ambiguous statements allow healthcare facilities to operate at or below minimum levels. That's all we're trying to say here, that standards are in place, statements are in place by the Joint Commission, and still there are problems. Okay, so what is the connection between worker and patient safety? Addressing worker safety and health issues can improve patient safety. How? Lifting and safe patient handling, of course, we said through mechanical means. Workplace violence, slips, trips, and falls, workplace transmission of infectious diseases. And Jonathan will go through some of the statistics, like I said, in a few minutes. Workplace exposure to angioplastic and other hazardous drugs, atenoplastic with chemotherapy. Suboptimal work organization resulting in stress, fatigue, and medical errors. Thank you very much.